Welcome to Mastering Section D, Mood, on the MDS assessment. In this video, we'll help you identify the various components of Section D, understand the coding instructions, accurately assess the resident's mood according to RAI guidelines, share interviewing techniques, and recognize the impact of Section D on care planning and how you can support the resident. The intention of this section is to assess the resident for signs and symptoms of mood distress and social isolation. Items included in this section will involve conducting a patient health questionnaire or staff assessment of resident mood and addressing any feelings of social isolation. Our section begins with item D0100, where we are asked if resident mood interview be conducted. Here, we will be simply determining if the resident is rarely or never understood, which is typically limited to residents that are not able to communicate verbally, in writing, or by using any other method. If the resident is at least sometimes understood verbally, in writing, or using another method, proceed to the interview. If not, skip to item D0500 to complete the staff assessment of resident mood. If in the preceding question it has been determined that an interview with the resident should be conducted, we will do this by utilizing a popular multi-purpose screening instrument called the Patient Health Questionnaire, or PHQ for short. This validated interview screens for symptoms of depression and provides a standardized severity score and a rating for evidence of a depressive disorder. While there are several different types of the PHQ, all varying in length, we will be utilizing version 2 to 9, which refers to the process of using a brief 2-item question to determine if the full 9-item questionnaire is warranted. The PHQ is a 2-part evaluation that asks the resident about the presence of specific symptoms and the frequency of those symptoms over the last 2 weeks. It is important that when conducting this interview, we read the item as it is written. Avoid providing definitions and ask each question in sequence, starting with symptom presence and symptom frequency, before proceeding to the next question. Symptom presence will be coded as 0 for not present, 1 for present, 9 for nonsensical responses, and dash if not assessed. For a symptom presence coded with 9, leave the symptom frequency blank. For any symptoms identified as being present, the following options for frequency will be available. 0 for never or 1 day, 1 for 2 to 6 days or several days, 2 for 7 to 11 days or half or more days, and 3 for 12 to 14 days or nearly every day. Our mood interview, or PHQ, begins with a brief 2-item screening, D0150A and B, otherwise known as the PHQ-2. Here we will ask the resident, over the last 2 weeks, have you been bothered by any of the following problems? Little interest or pleasure in doing things. Feeling down, depressed, or hopeless? For any yes response, code 1. Then proceed to ask the resident to tell you how often they were bothered by the symptom over the last 2 weeks, and present the frequency options for the resident to choose from. It is important to note, how the resident responds to those 2 particular items will determine whether or not the interview ends or progresses into a full PHQ-9. If the symptom presence was coded 9 for both questions, or the symptom frequency was coded as either 1 or 0 for both questions, you may end the interview and refer to the scoring rules to determine their overall severity score. For all other scenarios, proceed with the remaining 7 questions in items D0150C through I, using the same symptom presence and frequency format. Once you have completed the interview at either the 2 or 9 interval, we will determine the total severity score for item D0160 by using the following logic. If the symptom presence for the first 2 questions are coded 9 for nonsensical, and the interview has ended after D0150A and B, then the symptom frequency and the total severity score will be blank. If at any point the symptom frequency in items D0150A, 2 through I2 is blank for 3 or more items, override the total severity code to 99. Do not complete the staff assessment of mood, and skip to item D0700, social isolation. For all other scenarios where a symptom frequency was coded, regardless of our interview length, you will add up all of the symptom frequency scores to determine your total severity score. Enter the total score as a 2-digit number between 00 and 27. Here we will now review the steps to conduct a staff assessment of resident mood, otherwise known as the PHQ-9OV. The assessor will complete the staff assessment only when item D0100 is coded 0 for no. The resident interview should not be conducted, meaning the resident is rarely or never understood, cannot respond verbally, in writing, or by using any other method, or in the event the resident needs an interpreter, but one is not available. Similar to the instructions used when performing the resident interview, the staff assessment will utilize the same coding guidelines for symptom presence, frequency, and calculating the total severity score. Our steps for conducting a staff assessment of the resident's mood will involve interviewing the staff from all shifts who know the resident best. Encourage the staff to report symptom frequency, even if the staff believes the symptom might be unrelated to depression. Attempt to explore unclear responses, but focus the discussion onto the specific symptom listed on the assessment. If the resident has been in the facility for less than 2 weeks, talk to family or significant other and review transfer records to inform the selection of a frequency code. Now that we have reviewed the steps to assessing and calculating the total severity score, let's dive into the different severity score outcomes. A total severity score can be interpreted as follows: 1 to 4, minimal depression; 5 to 9, mild depression; 10 to 14, moderate depression; 15 to 19, moderately severe depression; and 20 to 27 or 30 for O.V, severe depression. It is important to note that coding the presence of clinical signs and symptoms of depressed mood does not automatically mean that the resident has a diagnosis of depression or other mood disorder. Assessors do not make or assign a diagnosis based on these findings. They simply record the presence or absence of specific clinical signs and symptoms of depressed mood. Facility staff should recognize these signs and symptoms and consider them when developing the resident's individualized care plan and involving the appropriate mental health professionals. In this section of our video, we'll be sharing a few techniques that you can use to fortify your evaluation skills, whether it is used during our resident interviews or in staff assessments. The first technique, and possibly the most utilized, is understanding the resident's intention if they have used their own words to describe a symptom. During our interview, we do not provide definitions since the meaning must be based on the resident's interpretation. If the resident uses their own words to describe a symptom, this should be explored. If you determine that the resident is reporting the intended symptom but using their own words, ask them to tell you how often they were bothered by that symptom and code accordingly. Probing is a technique that can be used to assist residents with non-committal responses, such as "not really." Residents may be reluctant to report symptoms and should be gently encouraged to tell you if the symptom bothered them, even if it was only some of the time. Probe by asking neutral or non-directive questions such as, "What do you mean?" or "Tell me more." "Tell me what you have in mind," or "Give me an example." Another technique, often referred to as echoing, is used to help narrow or redirect the answer to the choices available. For example, when asked about poor appetite or overeating, and the resident responds with, "The food is always cold, and it just doesn't taste like it does at home. The doctor won't let me have any salt." An echoed response by the interviewer would be, "You're telling me the food isn't what you eat at home, and you can't add salt. How often would you say that you were bothered by poor appetite or overeating during the last 2 weeks?" Disentangling is a helpful technique if a resident has moderate cognitive impairment but can respond to simple, direct questions. If the resident has difficulty with longer items, separate the item into shorter parts and provide a chance to respond after each part. For example, trouble falling or staying asleep, or sleeping too much can be broken down to, "How often are you having problems falling asleep?" Pause for response. "How often are you having problems staying asleep?" Pause for response. "How often do you feel you are sleeping too much?" So on and so forth. For items broken into several parts, and the resident has reported several frequencies, or has difficulty selecting between 2 frequency responses, code the higher frequency and continue. Lastly, Section D concludes with item D0700, social isolation. As social isolation tends to increase with age and is a risk factor for physical illness, mental illness, and a predictor of mortality, it is imperative that it is appropriately assessed, identified, and addressed. For this question, it is important to note that this item is intended to be exclusively a resident self-reported item, and that no other source should be used to identify the response. Here, you will ask the resident, "How often do you feel lonely or isolated from those around you?" If the resident indicates never feeling lonely or isolated from others, code 0 for never. Rarely feeling lonely or isolated from others, code 1 for rarely. Sometimes feeling lonely or isolated from others, code 2 for sometimes. Often feeling lonely or isolated from others, code 3 for often. Always feeling lonely or isolated from others, code 4 for always. If the resident declines to respond, Code 7, and if the resident is unable to respond, Code 8. Section D provides a platform for the resident's voice, ensures accurate detection of depression symptoms, elevates care planning, and safeguards the resident's quality of life, which is why coding accuracy is imperative. For more information on coding the MDS, or to see more MDS-related content, follow our channel at MDS Made Easy, brought to you by the Data Nurse, your partners in MDS Precision.